A very good evening to all the students. Welcome to IIMSC, Empowering People and Enhancing Education. Am I audible? If I'm not audible, please unmute yourself and you can ask me the questions. Any kind of query will be answered. Okay. Now, so today's topic of discussion is thyroid gland. Now let's just, yeah. So today our topic of discussion is thyroid gland. Anatomy wise and even surgery wise, thyroid gland forms a very important topic. Okay, in your anatomy paper and even in your future surgical aspect and surgery side, thyroid gland is a very important topic. Okay, thyroid gland's anatomy is very important to know because tomorrow when you're doing surgeries, there are a lot of procedures which will be doing concerned with the blood supply and nerve supply of thyroid gland. So knowing the anatomy of thyroid gland is of pivotal importance. Now, thyroid gland will be dealt under the following subheadings: location and extent, coverings, presenting parts, relations, blood supply, lymphatic drainage, nerve supply, and applied anatomy. So first subheading which we'll be talking today is location and extent. Okay, thyroid gland is situated in the middle of the neck, in the front of the middle of the neck. As you can see in the picture, this is the thyroid gland. It is present in front of the middle of the neck and its extent is, it extends from C5 to T1 vertebral levels. It extends from C5, C6, C7 and T1 vertebral levels. So once again I'll repeat: situation and extent of thyroid gland. It is situated in the front of the neck, midline, in the midline, and it extends from C5, C6, C7 and T1 vertebral levels. Next, we'll talk about coverings of the thyroid gland. As you can see, this is transverse section in the neck has been taken at this level, and this is that transverse section. Okay, it is taken at around C5, C6 level, and this is the transverse section. In this transverse section, you can see this cream colored part is your thyroid gland. Okay, thyroid gland has got two coverings: inner true, inner true capsule and outer false capsule. As you can see, the green part which you're seeing over here is the outer false capsule, and the black color lining which you're seeing over here is the inner true capsule. Okay, now again coming to this picture, this is the inner true capsule and this is the outer false capsule which you are able to see. The outer false capsule is derived from the pretracheal fascia, which is a part of deep cervical fascia. Deep cervical fascia is the deep fascia present in the neck. The deep fascia in the neck, the deep cervical fascia present in the neck will form one of the layers which is known as pretracheal fascia that will enclose the thyroid gland. As you can see, one part is coming from this side and another part is coming from this side and will enclose the thyroid gland. It is the outer false capsule. Okay, and the inner true capsule which you are seeing, this black line which is evident over here, is formed by the condensation of the peripheral part of the gland itself. By the condensation of the peripheral part of the gland itself, as you can see. Now what is condensation? It is just thickening of the outer part of the gland. It is just thickening of the outer part. The outer part of the gland tissue which was there, it got thickened to form the inner true capsule. One very important aspect about the outer false capsule, as you can see here, the outer false capsule is extending upwards and downwards. It extends upwards and gets attached to, as you can see, back of the thyroid gland, you're able to see thyroid cartilage. Thyroid cartilage is one of the cartilages of larynx. It is attached to the thyroid cartilage and also to the hyoid bone. It is attached to the hyoid bone, and below it extends into the thorax. As you can see, it extends into the thorax and it is attached to pericardium. What is pericardium? It is the serous covering. It is the covering of the heart. Pericardium is the covering of the heart. So the outer false capsule extends upwards and it is attached above to the thyroid cartilage and also to the hyoid bone. And below it extends downwards and it is attached to the pericardium. This is of lot of clinical importance next year when you go to clinics and when you are examining a neck swelling. Now, how to make out whether it is a thyroid swelling or a non-thyroid swelling? With this attachment, because it is attached about the hyoid bone and the thyroid cartilage, whether to know the swelling is of thyroid origin or non-thyroid origin, how are we going to make out? It's very easy. If we ask the patient to make swallowing movements, just do swallowing movements, and if you see that the swelling is moving up, if the swelling is moving up, then it is definitive that it is concluded that it is a thyroid swelling. Okay, it is a thyroid swelling. Why does it move? Because of this attachment. Because of this attachment, the thyroid swelling moves, moves upwards whenever we ask the patient to swallow. So this attachment of the outer false capsule is very, very important. Now, one more surgically relevant point about the coverings. Again, in this picture, if you can see, this is the outer false capsule and this is the inner true capsule and this is the thyroid gland. Now, this point also has got a lot of surgical importance. Whenever we want to do thyroidectomy operations, what do you mean by these thyroidectomy or ectomy operations? You just suppose if the thyroid gland becomes cancerous, if any cancer develops in the thyroid gland, then you have to remove the entire thyroid gland. That procedure of removal is known as thyroidectomy. Now, in the outer false capsule, as you can see, and the inner true capsule, beneath the inner true capsule, you can see here there are presence of veins, venous plexus which drains the thyroid glands. Okay. Now, what is very important about it? We have to remove the gland along with the inner true capsule. Inner true capsule. Why is it very important? If you try to cut the inner true capsule, in surgical terms, incise the true capsule. Here you are able to see, this is the true capsule. If you are trying to incise the inner true capsule, you can even incise the veins. Even the veins can get cut and that will lead to heavy bleeding. There will be a lot of blood loss. There will be profuse blood loss that will lead to further complications. So the procedure to avoid this blood loss is you should remove the thyroid gland without incising the inner true capsule. Okay, beneath the false and true capsule, you have the thyroid plexus of veins. Lot of importance is there. Okay. Next, we'll talk about the presenting parts. So we finished the coverings. The coverings are inner true capsule. As you can see here, this is the inner true capsule and this is the black line is the inner true capsule and this is the outer false capsule. Okay, in between the inner true capsule and outer false capsule, you'll be also seeing parathyroid glands that we'll discuss later. Now we'll come to the presenting parts of the thyroid gland. As you can see in the picture, the thyroid gland has got two lobes, lobe 1 and lobe 2, and the middle connecting part is known as the isthmus. The middle connecting part is isthmus. Okay, now each lobe of the thyroid gland will have an apex and a base. I'll show them in the subsequent slides. You have an apex and base. You have got three surfaces and three borders. What are those three surfaces and three borders? I'll show in the subsequent slides. Now first we'll talk about the relationships of apex and base. In this slide, we are able to see the relationships of the apex. This is the apex of the gland. Here you will be having base of the gland. Okay. This is another picture. Here you can see this is the apex and this is the base of the gland. This is the midline connecting isthmus. These are the two lobes. Okay, what are the surfaces? I'll show in this picture. These are the three surfaces. So each lobe, this is one lobe, this is another lobe, and this is the middle isthmus. This is transverse section of the neck. This picture is the transverse section of the neck. This you are viewing from the front. This is full thyroid gland, while this is the transverse section. While in this picture you are only seeing one lobe of the thyroid gland. You are seeing only one lobe of the thyroid gland. Okay. So here you can see this is the apex and base. Now in the previous picture, now in the coming picture you will see only the apex region. The apex is related to one artery and one nerve. Generally artery should be colored yellow, but here to differentiate from the gland, it has been colored black. Okay, then the apex of the gland is related to one artery and one nerve. As you can see here, this is the superior thyroid artery and this is the external laryngeal nerve. This is the superior thyroid artery and external laryngeal nerve. You can see in this picture also the apex of the gland is related to one artery and one nerve. The artery is superior thyroid artery and the nerve is external laryngeal nerve. Okay, superior thyroid artery and external laryngeal nerve. It is also related to two muscles. As you can see here, it is related to inferior constrictor muscle. It is a muscle of pharynx, and one more muscle is sternothyroid. You can see in this picture. So the relationships of apex of the thyroid gland are four. One is external laryngeal nerve, 2 is superior thyroid artery, 3 is inferior constrictor muscle, and 4 is sternothyroid muscle. Okay, one very important point which we can notice in this picture is near the apex, the superior thyroid artery and the external laryngeal nerve are diverging. Both the artery and nerve are diverging. This has got a lot of surgical importance. This we'll discuss in the applied aspects point. Okay. The artery runs in front of the gland while the nerve runs behind the gland. You can see it is a dotted line. In our diagrams, if we see dotted line means it is posterior. Okay. Now we'll talk relationships of the base. Okay. Apex was related to one artery and one nerve. Even base is also related to one artery and one nerve. What is that artery and nerve? Here it was related to external laryngeal nerve. This is related to recurrent laryngeal nerve. Here it is related to superior thyroid artery. Here it is related to inferior thyroid artery. So you have one artery and one nerve related at the apex, one artery and one nerve related at the base. The artery related at the apex is superior thyroid artery, while the one present at the base is the inferior thyroid artery. The nerve present at the apex is external laryngeal nerve, while the nerve present at base is in recurrent laryngeal nerve. Now we'll talk about relationships of the surfaces. Till now I didn't tell what are the three surfaces. This is one lobe. If you are not understanding this picture, please ask. This is transverse section taken in the neck. Okay, transverse section taken in the neck. So this is one lobe, this is another lobe, and this is the isthmus connecting both the lobes. Now I'll show you what are the three surfaces. Okay, this is the anterolateral surface, this is the medial surface, and this is the posterior surface. Okay, you have anterolateral surface, posterior surface, and medial surface. This is of one lobe, and this is anterolateral surface, posterior surface, and medial surface of another lobe. Okay, these are the surfaces. So these are the two lobes, and this is the isthmus, and the surface of the lobes, once again I'll repeat, anterolateral, posterior, and medial surface. Now we'll talk about the relationships of the anterolateral surface. Anterolateral surface is related to four muscles. As you can see, here you have four muscles, here you have four muscles. So the four muscles from inside out are: number 1, sternothyroid; number 2, sternohyoid; number 3, omohyoid; and number 4, sternocleidomastoid. Okay, so you have four muscles. Once again I'll repeat. You have the sternothyroid, sternohyoid, omohyoid, and sternocleidomastoid. So these are the relationships of the anterolateral surface. Anterolateral surface is also known as superficial surface. This is one anterolateral surface of one lobe. This is anterolateral surface of another lobe. Then we'll talk about relationships of the posterior surface. As you can see in the picture, the posterior surface is related to carotid sheath and its contents. Carotid sheath and its contents. So what are the contents of the carotid sheath? The contents of the carotid sheath are common carotid artery, internal jugular vein, and vagus nerve. So the relationships of the posterior surface are carotid sheath and its contents. You have common carotid artery, internal jugular vein, and vagus nerve. Now what are the relationships of medial surface? The relationships of the medial surface are two tubes, two nerves, and two muscles. The two tubes which you are seeing here is, one is trachea and the other one is esophagus. Okay, one is trachea, another one is esophagus, the two tubes. Then what are the two nerves related to it? You're able to see this is nerve number 1, this is external laryngeal nerve, and this is nerve number 2, that is the recurrent laryngeal nerve. So the two nerves related to the medial surface are external laryngeal nerve and recurrent laryngeal nerve. And what are the two muscles which are related here to the medial surface? Inferior constrictor and cricothyroid muscles. So the two muscles which are related to the medial surface are inferior constrictor and cricothyroid muscles. You can see here, once again I'll repeat the relationships of the medial surface. It is related to two tubes. One is trachea, another is esophagus. Two nerves, external laryngeal nerve, recurrent laryngeal nerve. Two muscles, inferior constrictor and cricothyroid muscles. Once again I'll repeat the relationships of the surfaces. Anterolateral surface is related to four muscles, that is sternothyroid, sternohyoid, omohyoid, and sternocleidomastoid. These are all neck muscles present in the anterior aspect of the neck. Then posterior surface is related to carotid sheath and its contents, which include internal jugular vein, common carotid artery, and vagus nerve. Then you have relationships of the medial surface. It is related to two tubes, trachea, esophagus, two nerves, external laryngeal nerve, recurrent laryngeal nerve, and two muscles, inferior constrictor and cricothyroid muscles. Next we'll talk about relationships of the borders. We have two borders, namely one border will be present over here, another border will be present over here. One is anterior border, another is posterior border. You can see in this picture, this is the anterior border. This is the anterior border. As you can see, what is the relationship of the anterior border? The anterior border is related to the superior thyroid artery. Anterior border is related to a branch of superior thyroid artery. In this picture, you are seeing relationships of the posterior border. You are seeing relationships of the posterior border. Posterior border is related to anastomosis between, as you can see, this is the superior thyroid artery and this is the inferior thyroid artery. The posterior border is related to anastomosis. Anastomosis is the meeting point between two blood vessels. Anastomosis between superior thyroid artery and inferior thyroid artery. And you can also see two glands over here, parathyroid glands. It includes two parathyroid glands. Posterior border is related to the anastomosis between superior and inferior thyroid arteries and parathyroid glands. Two parathyroid glands here and two parathyroid glands here. So these are the relationships of the borders. Okay, now we'll talk about, so we have finished the relationships of the lobes. Now we'll talk about relationships of the isthmus. Isthmus. What is the relationship of the posterior aspect of the isthmus? Posteriorly, you are able to see the trachea. Posteriorly, you are able to see the trachea. Posteriorly, it is related to second, third and fourth tracheal rings. Second, third and fourth tracheal rings. And anteriorly, it is related to these muscles, isthmus, that is sternothyroid, sternohyoid, and here you will be having one very important vein, that is the anterior jugular vein. Anterior to this, you have skin and superficial fascia. So the relationships of the isthmus posteriorly is trachea, and anteriorly you have sternothyroid, sternohyoid, skin, superficial fascia and anterior jugular vein. Now here in this picture, what is related to the upper border and lower border of the isthmus? This is the upper border of the isthmus and this is the lower border of the isthmus. Upper border of the isthmus is related to anastomosis between two superior thyroid arteries, while the lower border is related to two veins and one artery. These two veins are inferior thyroid veins and the artery is arteria thyroidema. The name of the artery is arteria thyroidema artery. Then, so this finishes the relationships of isthmus 2. Once again, I'll repeat the borders relationships of isthmus. Upper border is related to anastomosis between superior and inferior thyroid, two superior thyroid arteries, while the lower border is related to two veins, inferior thyroid veins, and one artery, that is arteria thyroidema. Now we'll talk about blood supply of thyroid gland. Thyroid gland is supplied by three arteries. Number 1, superior thyroid artery. Number 2, inferior thyroid artery, and number 3, thyroidema artery. Just now I had discussed near the isthmus, near the lower border, you are seeing one artery, that is the thyroidema artery, also known as arteria thyroidea. So superior thyroid artery, which is a branch of external carotid artery, and inferior thyroid artery, it is a branch of thyrocervical trunk. So the blood supply of thyroid gland is arterial supply, which is superior thyroid, this is superior thyroid artery, this is the inferior thyroid artery, and this is arteria thyroidema. Then we have venous drainage. Venous drainage is also by three veins. One is superior thyroid vein, this is inferior thyroid vein, and this is the middle thyroid vein. Middle thyroid vein. We need to, whenever we are doing thyroid surgeries, we need to be very careful about the inferior thyroid artery. Generally it is not present, but whenever we are doing thyroid surgeries, before the removal of thyroid, we have to search this vein and ligate the vein. Ligature means you are tightly closing the vein by putting a suture. Okay, if you don't suture this and if you try to remove the thyroid gland by cutting this vein, then there will be profuse bleeding. Okay, so coming back to venous drainage, you have superior thyroid vein, middle thyroid vein, and inferior thyroid vein. Superior thyroid vein drains into internal jugular vein. Middle thyroid vein also drains into internal jugular vein, while the inferior thyroid vein drains into the left brachiocephalic vein. Very evident in the picture. Superior thyroid vein drains into internal jugular, middle thyroid drains into internal jugular, and inferior thyroid drains into left brachiocephalic vein. Now we'll talk about lymphatic drainage of thyroid gland. Okay, very simple. The upper half of the thyroid gland drains into prelaryngeal group of lymph nodes, while the lower half drains into pretracheal group of lymph nodes. This is prelaryngeal group of lymph nodes, and this is pretracheal group of lymph nodes. Okay, pretracheal group of lymph nodes. This is the lymphatic drainage of thyroid gland. Now nerves of the thyroid gland. Excuse me? Hello? Yes. Now I'll continue with the nerve supply. See, basically the function of thyroid gland is production of thyroxine hormone. That stimulus comes from anterior pituitary. See, as you can see in this picture, this is hypothalamus. Hypothalamus is releasing TRH, thyroid releasing hormone, which acts on pituitary gland. Pituitary gland will release thyroid stimulating hormone, that is TSH, and this TSH will come and act on thyroid gland, and that will make us produce the T3 and T4. Okay, but for the sake of completion of the topic, the nerve supply of thyroid gland is sympathetic nerve supply is coming from superior, middle and inferior cervical ganglion, while parasympathetic nerve supply is coming from vagus. Always remember, if you don't know what is the parasympathetic nerve supply of any organ, you can bluntly write vagus nerve. So the sympathetic nerve supply is coming from superior, middle and inferior cervical ganglion, while the parasympathetic is coming from vagus nerve. Now we'll talk about the applied aspects of thyroid gland. Applied aspects are broadly divided into two groups, congenital and acquired. Congenital are coming because of some genetic defect and they are present from birth. Acquired, they are acquired during the postnatal life. Now, in congenital, see, this is ectopic thyroid. Normally where thyroid gland should be present, this is the place where normally thyroid gland should be present, from C5 to T1 vertebral levels. But thyroid gland can be present near the tongue, that is known as lingual thyroid, or over the hyoid bone, this is the hyoid bone, above the hyoid bone known as suprahyoid, or below the thyroid, infrahyoid, or here just at the level of pyramidal lobe. So anywhere, ectopic thyroid means presence from its normal sites. Normally it should be present over here from C5 to T1, but here it is present at abnormal sites. Presence of abnormal sites, presence of thyroid tissue at abnormal sites is known as ectopic thyroid. Okay, now this is a case of thyroglossal fistula. Thyroglossal fistula. Okay, if the thyroid gland starts from here and ultimately reaches this level. During the process of development, thyroid gland develops here and it reaches here. Okay. If it fails to, if it tries to open onto the surface, then it will result in thyroglossal fistula. This thyroglossal fistula can become infected and the treatment is complete removal of this fistula. Then, how do you palpate for thyroid gland? This is the procedure how you palpate the thyroid gland. Thyroid gland is present. To palpate the thyroid gland, the doctor should go behind the patient and keep both their fingers in front of the neck and try to palpate with these three fingers. That is your index finger, ring finger, and middle finger and ring finger. On both sides simultaneously you should palpate, then only you will get an approximate idea about the thyroid gland. Then what is this? This is enlargement of thyroid gland. The term used for enlargement of thyroid gland is known as goiter. Okay, goiter. She is a lady who has got goiter. As you can see here, there is enlarged thyroid gland. Okay, and she is presenting with symptoms of thyrotoxicosis, that is increased thyroid hormone production. As you can see, her eyes are bulged out. This is known as exophthalmos. This is known as exophthalmos. We'll see the features. What are the features of thyrotoxicosis or hyperthyroidism? You can see the person has become very thin because of increased metabolic rate. All the glucose and all the stored fat is being exhausted, and this person just cannot tolerate heat because from his body only lot of heat is being produced, so this person will be profusely sweating. Okay, and there will be exophthalmos, and there will be breast enlargement, there will be tachycardia, there is increased systolic BP. What is tachycardia? Increased heart rate. And there will be also muscle wasting. These are the features of hyperthyroidism. Once again, I told you that there is very importance about the relationship of the artery and vein near the apex and the base. What is the artery which is the nerve? The artery which is there here is the superior thyroid artery, and the vein which is there is the external laryngeal nerve. Sorry, I said vein. This is the nerve, external laryngeal nerve and superior thyroid artery. Here you have inferior thyroid artery and recurrent laryngeal nerve. These two are moving away from the gland. Okay, I'll just come to the point. When we are ligating during the surgery for thyroid, these two nerves are ligated near the gland, while the artery and the nerve here are ligated away from the gland. As you can see, away from the gland, they are far apart. Near the gland, here they are present. Near the gland, they are moving apart from each other. Okay, so the ligature has to be applied here near the gland and here away the gland. Away the gland, they both are apart. Always remember, never ever in ligature a nerve should be included. So this finishes my class on thyroid gland, and thank you very much for joining in this session. Any doubts? Please, if there are any doubts, you can please ask them. I am waiting for your doubts.
Hello, sir.
Yeah, Anudeep. Yeah.
Can you please repeat about the borders of isthmus?
Borders of isthmus. Yeah, just hold on for a second. You want borders of isthmus or borders of the thyroid gland, lobe? Anudeep.
Borders of isthmus.
Okay. Isthmus has got only two borders. You can see this is the isthmus. This is the middle part. This is the isthmus. Able to see, Anudeep? This is the isthmus region.
Yes, sir.
It has got only superior border and inferior border. Superior border is related to you. Are you able to see? This is the superior thyroid artery from here. This is superior thyroid artery from here. Superior border is related to anastomosis between two thyroid arteries, while the inferior border is related to two thyroid veins, which are the inferior thyroid veins, and one artery. This is arteria thyroidema artery. Clear, Anudeep? Or shall I repeat it once again?
Yes, sir. Thank you.
Okay, any more doubts? I'm waiting for your doubts.
Sir,
Yes.
explain about the lymphatic system.
Lymphatic system. Yes. As you can see in this picture, you have two groups of lymph nodes draining the thyroid gland. You have one set which is present above. It drains the upper half of the thyroid gland. This is known as prelaryngeal group of lymph nodes. And you have one more set of lymph nodes which is present below. Those are known as pretracheal group of lymph nodes. These lymph nodes will drain upper half of the thyroid gland. These lymph nodes will drain the lower half of the thyroid gland. Prelaryngeal and pretracheal group of lymph nodes. Clear? Gautam, was it Gautam who asked the doubt? Gautam? Hello Gautam, has your doubt been cleared?
Yes, sir.
Okay Gautam, any more doubts?
Sir, can you please explain about palpation of thyroid gland also?
Okay, now you can see in this picture, the doctor is standing behind the patient and the patient is present in front. You need to stand behind the patient and with both your fingers simultaneously you need to palpate. With your three fingers, that is your middle finger, index finger and ring finger. You need to place it in the midline region in front of the neck and palpate for the thyroid gland. See, generally you won't be able to palpate. If there is any swelling or if it is any lump or any mass is there, then you will be able to easily palpate the gland. Gautam, understood?
Yes, sir. Thank you so much.
Okay. Okay, Gautam. Any doubts? Any more doubts? I'm waiting.
Sir,
Yes, Anudeep.
as you said that the relationship with the effects of the gland, you said that the artery and the nerve must be ligated near the gland.
Yes, yes.
As you have said.
Yes.
What is the clinical importance of that?
See, whenever you do surgeries, thyroidectomy surgeries, did you understand the meaning of thyroidectomy?
It's a removal of thyroid gland.
Removal of thyroid gland. See, always, do you understand the word ligation, ligature?
Yes, sir.
You need
Suture, applying.
you have to apply the suture around the artery. If you don't apply the suture, what will be the consequences? If you remove the thyroid gland, there will be profuse bleeding. Did you get this point, Anudeep?
Yes, sir.
Now, see, if you can see in this picture, near the apex of the thyroid gland, the artery is running in the front and the nerve is running behind. Is it clear, Anudeep, this point?
Yes.
Artery is running in
Yes,
the
sir.
front, nerve is running in the behind. Okay, so what is happening? The artery and nerve are diverging near the apex. Did you get this point, Anudeep? Artery and
Yes,
nerve
sir.
are diverging near the apex. So what are they doing? They are separating near the apex. They are separating near the apex. Now, whenever you apply ligature, you need to take care that never ever nerve should be included in the ligature. Because once nerve has been included in the ligature, the nerve will get permanently damaged. So, because they both are separating near the gland, away from the gland, they both are in close proximity. See, if they are coming from here, they are present in close proximity away from the gland. As they are coming near the gland, they both diverge. So, which place would you choose to ligate? Away from the gland or near the gland, Anudeep?
Near the glands.
Because they both are diverging over there. But when it comes to base, here you have the inferior thyroid artery and recurrent laryngeal nerve. You can see away from the gland, they both are separate from each other. That's why, where will you ligate here? Will you ligate near the gland or away the gland?
Away from the glands.
Away from the gland. So that is the, so did your doubt get cleared, Anudeep?
Yes, sir. Thank you so much, sir.
Okay. Any more doubts? So I'm closing this. Yeah. Anyone, please. So I'm closing the session. Thank you everyone for being a part of this session. Please give your feedbacks.